Hello and welcome. Today we'll be discussing the impact of tumors, particularly meningiomas, on the auditory nerve and the resulting effects on vision and hearing. We'll explore how these tumors develop, the symptoms they cause, and the available treatment options. The primary cause of auditory nerve compression, in the context we're discussing, is the growth of a tumor near the nerve itself. While many types of tumors can potentially exert this pressure, meningiomas are a frequent culprit. Meningiomas arise from the meninges, the membranes that surround the brain and spinal cord. It's important to note that, in most cases, the exact reason why these tumors develop remains unknown. Some genetic factors, like neurofibromatosis type 2, can increase the risk, but these are relatively rare. Exposure to radiation, particularly in childhood, has also been linked to an increased risk, although this is less common now with modern radiation therapy techniques. The auditory nerve, also known as the vestibulocochlear nerve or cranial nerve V2, plays a critical role in both hearing and balance. When a tumor, like a meningioma, grows near this nerve, it can physically compress it. This compression disrupts the nerve's ability to transmit signals effectively from the inner ear to the brain. The result is a range of auditory and vestibular problems. Now, regarding vision, tumors in this area, especially if they grow large, can also compress the optic nerve or the optic chiasm, the area where the optic nerves from each eye cross. This compression can lead to visual field defects, reduced visual acuity, or other visual disturbances. The severity of the symptoms depends on the size and location of the tumor, as well as the degree of compression on the nerves. Meningiomas in general are relatively common brain tumors. They account for a significant percentage of all primary brain tumors. However, not all meningiomas compress the auditory nerve or affect vision. The incidence of meningiomas that specifically impact the auditory and optic nerves is lower and depends on their location relative to these structures. They are more common in women than in men, and their incidence increases with age. The likelihood of developing a meningioma also varies among different populations and ethnic groups, but more research is needed to fully understand these differences. The signs and symptoms of a tumor compressing the auditory nerve can vary depending on the size and location of the tumor, as well as the degree of compression. Common auditory symptoms include hearing loss, which may be gradual or sudden, tinnitus, described as ringing or buzzing in the ears, and dizziness or vertigo, a sensation of spinning, because the vestibular portion of the nerve controls balance. Visual symptoms can include blurred vision, double vision, loss of peripheral vision, or complete vision loss in one or both eyes. Headaches are also a common symptom, particularly if the tumor is large or causing increased pressure within the skull. Other symptoms may include facial numbness or weakness, difficulty swallowing, or changes in speech, especially if the tumor is affecting other cranial nerves. It's important to note that some individuals may experience only a few of these symptoms, while others may experience a wider range. Diagnosing a tumor compressing the auditory nerve typically involves a comprehensive neurological examination. This will assess hearing, balance, vision, and other cranial nerve functions. Audiometry, or hearing tests, will be performed to determine the extent and nature of any hearing loss. Vestibular testing will assess balance function. An eye exam including visual field testing is crucial to assess any visual deficits. The definitive diagnosis usually requires neuroimaging, such as MRI or CT scans. MRI is generally preferred, as it provides more detailed images of the brain and surrounding structures, including the auditory and optic nerves. These scans help to identify the presence, size, and location of the tumor. In some cases, a biopsy may be necessary to confirm the diagnosis and determine the specific type of tumor. However, this is not always required, especially if the imaging is highly suggestive of a meningioma. Meningiomas are often classified based on their histological grade, which reflects how abnormal the tumor cells appear under a microscope. Grade I meningiomas are the most common and are considered benign, meaning they grow slowly and are less likely to recur after removal. Grade I meningiomas are considered atypical and have a slightly higher risk of recurrence. Grade II meningiomas are malignant, meaning they are more aggressive and have a higher risk of recurrence and spread. In the context of auditory nerve compression, the location of the meningioma is also a critical factor. Meningiomas that arise near the cerebellopontine angle, the area where the brainstem meets the cerebellum, are more likely to compress the auditory nerve. Treatment and management strategies for tumors compressing the auditory nerve depend on several factors, including the size and location of the tumor, the patient's age and overall health, and the severity of their symptoms. Observation, also known as watchful waiting, may be an option for small, slow-growing tumors that are not causing significant symptoms. Regular monitoring with MRI scans is essential to track tumor growth. Surgery is often the primary treatment option for larger tumors or those causing significant symptoms. The goal of surgery is to remove as much of the tumor as possible while preserving the function of the auditory and optic nerves. Stereotactic radiosurgery, such as gamut knife or cybert knife, is a non-invasive treatment option that uses focused beams of radiation to target the tumor. This may be used as a primary treatment or after surgery to treat residual tumor cells. Radiation therapy using external beam radiation may be used for larger tumors or those that cannot be completely removed surgically. Medications, such as corticosteroids, may be used to reduce swelling and inflammation around the tumor. Hearing aids or cochlear implants may be used to manage hearing loss. Assistive devices and visual rehabilitation may be helpful for managing visual deficits. While there is no definitive way to prevent the development of meningiomas in most cases, minimizing exposure to known risk factors, such as ionizing radiation, may be prudent. Genetic screening and counseling may be appropriate for individuals with a family history of meningiomas or genetic syndromes associated with increased risk, such as neurofibromatosis type 2. Regular neurological check-ups and imaging may be recommended for individuals at high risk. The prognosis for individuals with tumors compressing the auditory nerve varies depending on several factors, including the type and grade of the tumor, the extent of surgical removal, and the patient's overall health. For benign meningiomas that can be completely removed surgically, the prognosis is generally good. However, recurrence is possible, even with benign tumors, so long-term follow-up is essential. For more aggressive tumors, the prognosis is less favorable. Recent research has focused on identifying new drug targets and developing more effective therapies for meningiomas. Immunotherapy, which harnesses the body's immune system to fight cancer, is being investigated as a potential treatment option. Advances in surgical techniques and radiation therapy have also improved outcomes for individuals with these tumors. Researchers are also investigating genetic and molecular markers to better predict tumor behavior and response to treatment.